Well, hello, everybody. This is Shari Welch, and I'm here with Kevin Klauer for another issue of ED Leadership Monthly. It's February 2018, folks, and we've got a lot of great stuff to share with you, discuss with you, show you. So we're glad that you could join us. I feel like I might be beating a drum, and yet I feel like it's important talking to you about the ED inpatient interface. And I'm going to do it again. So apologies up front for this. But I want you to be aware of an article about that links delayed discharges and boarders. And it's actually from Emergency Medicine Journal, September 2016. And they just looked at the relationship. The authors looked at late hospital discharges and boarding. And they found that 15% of beds were occupied by patients that could be going home. And everybody is, Kevin, are you finding this across the country? I think combination of the flu season and hospitals are at occupancy or higher. I mean, what I'm hearing and seeing is everybody's fighting with boarding. Right, Kev? What are you finding?
No, absolutely. And what I heard last week was, I think it was 9 or 9.8% of our outpatient visits, so ED visits, were all attributed to the flu. I mean, you look at one disease entity, that's massive, which we look at it this way too. In certain times of the year, it's zero.
Yeah.
There's nothing. So has that changed what's been going on out there? Absolutely. Does it make bed space at a premium? Does it amplify and magnify the issues with boarding? Absolutely it does.
Yep. So it's just kind of like a double whammy. Now, what I wanted to point out to you is that whether or not you get your discharges out early in the day, this is huge for you in the ER, and yet you may not feel that connection. But this was one of a number of studies that are showing this. A few other data points that I fleshed out in some inpatient work that I've done that I thought you might find useful. 1 in 4 patients in a hospital bed right this minute no longer need acute medical care. And if anybody wants the references, I'll go offline and give you, because I got a little library on this that I started because I was just fascinated by it. 1 in 4 are waiting for something. Maybe it's a nursing home bed. You know, there are patients that are too, medically ill to go home and need some support. Maybe they're waiting for home health to be set up. Maybe they're waiting for transportation. We've talked about some of these things. And then 1 in 5 patients on the inpatient side is experiencing some of these delays that we were talking about. And so I want you to seem really, really smart when you are going to medical staff meetings, MEC meetings with administration, that you understand that there's a relationship between not getting patients out, having long lengths of stay, and late discharges that really impacts the ER. What do you say, Kev?
Well, I say the same thing you say, Shari. What's frustrating to me is you and I have been having this conversation, not necessarily every month, but through this series for a decade. And these conversations started even before that. There should be enough awareness of the issue to start developing solutions.
Yep.
I can't believe this many years we've been saying, well, people are using bed capacity in a hospital and they no longer need care. And yet we're suffering from boarding and other issues and lost revenue on the hospital side. When are we going to, meaning all of us in healthcare, take a look at the utilization of beds and steal back whatever we can, not just saying it's only worth it if we can cut off a couple days of utilization. We need to start cutting minutes and hours off.
Yep. And one thing that is going to be a real sort of change in the approach of the providers on the inpatient side, very often in the past, someone, say a hospitalist or even other specialists, might keep somebody in the hospital to get, say, one more test. This has really got to change, and doing everything for the patient before they go home is no longer an option because nobody has this capacity. Capacity management is a very big theme for hospitals who are struggling with it. Now, this said, Kevin, I don't want any of our listeners, our medical directors, physician leaders, nurse leaders, to go banging your fist on the table with the hospital leaders. You got to fix boarding. And here's why. It's not a quick fix. I suppose you could shut down your surgery altogether and make those be medical beds. Then you've got a hospital that's likely not going to be viable if they can't still do their surgical procedures. And so I have one medical director that he and I worked on a wonderful project. We're doing great. They're very much plagued by boarding. And he has alienated his hospital leadership by saying, you fix boarding. The ER, we're not doing anything else until you fix boarding. it's not a quick fix, my friends. And I will tell you from doing some work on the inside, there's not a switch to be flipped. And people are working on this whole capacity management, which translates into boarding in the ER. Yeah, go ahead, Kevin. You have the final word.
Well, thank you, Shari. I think we need to fix our problem through fixing their problems. How can we as leaders be solutions for other people's issues, knowing that if we help them, if we're really smart about picking things we can help others with that aren't necessarily directly related to the ED, that we help the ED performance also. So if we know they're having troubles with these type of things, discharges before noon. I mean, Shari, you've brought a lot of information for discussion over the last few months about that concept. How can we help? Some leaders might say, well, that's not an emergency medicine issue. I'm not going to deal with it. And then when you say, I need boarding fixed, what do they say? Well, that's not a hospital issue. That's an ED issue. I think we need to share and participate in all of the issues so that we stop creating barriers to solutions to important problems based on where we work.
Yep. And I'll tell you a couple things that you can bring to the boarding discussion, just understanding that things like, transportation and having meds ready and having walkers for people that need durable medical equipment, that you understand some of the barriers of getting people out. That's going to be huge to show that you sort of understand their world. What can the ER do? I think we brought this up a couple of times. The ER could actually be a place for some follow-up visits. Places are doing that, early morning visits. ER can be a place where people come back through for perhaps more diagnostic testing. We got them out a day early, but they still need this test. So there's ways you can get in the game with your colleagues. And I would suggest that kind of approach, as Kevin says, in the game with them, not against them, not adversarial. How can we do it together? All right, Kevin, you have something kind of new, and I think it's something that's kind of exciting, might be a game changer. Talk about under Big Brother, this access. It's, I think, capital ACCESS legislation. Will you talk about that?
Basically what we're talking about is early in February when the House and the Senate passed a 2-year budget agreement so that we could avoid a shutdown. Now, it's going to fund the government through March 23rd, so we're going to maybe have this discussion again to a certain extent. It raises the debt ceiling, but a couple of things that came out of it which are really important, and I think my understanding formally, and maybe others too, is, okay, they get together, they decide how to fund the government, and it should be easy. Well, when you see all of the things that go into doing this and the add-on pieces that people put into it, I see why it takes some time. So what it did to impact emergency medicine, a couple things, it provided $90 billion in disaster relief funding for victims of recent hurricanes and wildfires, $6 billion in additional money to address the opioid epidemic. So there's several things going on with this that maybe wouldn't have happened if we weren't forced to deal with the shutdown. And Shari, I'm going to try not to spend a lot of time, but that's exactly what I'm going to do. I'm going to spend a lot of time. That ACEP has put a nice summary out there, and I want to go over a few of the things that ACEP has identified and others have identified that might be impacting emergency medicine through that act. And I think it's helpful to know what's happening, and hopefully the majority of this won't get undone. So the first thing is under Section 50101, hey, there's a funding extension for the CHIP program, Children's Hospital Insurance Program. We were worried that this might not get funded. It's now going to get funded through 2027. So that's a real positive that came out of it too. 50201, Medicare extenders. So there is an extension of Work Geographic Practice Cost Index, the GPCI floor. And this is basically what it does without going into too much detail, because there is a whole list of items, pages of items that have come out of this thing that impact healthcare. So this section would increase payments for the work component of physician fees in areas where labor cost is determined to be lower than the national average by extending the current 1.0 physician work GPCI floor for 2 years through December 31st, 2019. So that protects our environment a bit. Medicare ambulance services are being protected. So it would extend the temporary increase in ambulance fee schedule rates for all ground ambulance services and the super rural ambulance add-on payments for 5 years through December 31st, 2022. So a couple other things that maybe we didn't even know were at risk, but now we know are going to be protected. And I'll just hit a couple other topics without going into huge detail. But extension of funding for quality measure endorsement, input and selection, and the reporting requirements. You know, it was Section 183 of the Medicare Improvements for Patients and Providers Act of 2008 that required Health and Human Services to contract with a consensus-based entity like the NQF to look at measures and make sure you're including clinicians in the development of these things. That was going to go away, but it looks like that's going to continue, which is a great thing. A couple other things. I'm scrolling down the page here, the things that would help us. Adapting benefits to meet the needs of chronically ill Medicare Advantage enrollees. There's a very detailed explanation, but basically it would do a lot of things, including expanding the testing of CMMI value-based insurance design. This is a model to allow basically this Medicare Advantage plan in any state to participate in the model up to 2020 to determine whether savings can be achieved without having a negative impact on quality. So this extends that program. It would have been ended before it was really completed to see if it really works or not. Another one is providing accountable care organizations the ability to expand the use of telehealth. We want telehealth to be expanded. Expanding the use of telehealth for stroke. That also impacts emergency medicine. Who would have ever known that these things were considered in a budget discussion to avoid a shutdown? Providing prescription drug plans with Parts A and B claims data to promote the appropriate use of medications and improve health outcomes. There are a bunch of these. It's just over 20 pages worth of information. So I'll stop there unless there's anything you want me to look up or look into, Shari. But I think there are some huge wins for healthcare and some very specific wins for emergency medicine because the House and the Senate were able to get together in early February and avoid a shutdown.
Yeah, and Kevin, I was really surprised too. I had no idea that some of these things that so readily impact us were afoot with the budget threat of shutdown.
Well, one, too, that I absolutely don't want to forget to speak about is really GME funding. So this extends and increases funding for GME programs from $60 million per year to $126.5 million for each of the fiscal years 18 and 19. I didn't know that this was at risk, and we were able to get more funding. So that is a real positive thing also.
Oh, Kevin, I hadn't even put this on the agenda, but it just pumped in my mind. Yesterday I was on the plane, and I was sitting next to a fellow, a really bright fellow. He was a surgeon by training who then also went to law school. And he'd for many years defended physicians. Now he was actually prosecuting for cases, but he said he was very selective, and a case really, really had to have merit. I was sweating by the time I got done with my discussion with this guy, Kevin, because there were so many cases. But you know what he said, and I'm just throwing this out there, especially I think this is of interest to our leaders who are medical directors. He said that he has had a surge in malpractice cases that he thought were meritorious. A lot of times they go through pre-lit. He's in the state of Florida. They go through pre-lit panels that were attributable to physicians within 5 years of coming out of training. And he said, in fact, he had a bunch that were physicians just a year out. And so you and I have talked about this, Kevin. Have we reduced resident hours and reduced training and reduced the experience to the point that we now have people in practice that are not as sure-footed as they should be?
Yeah, I don't know, Shari, but I will say it's a valid question to raise. That have we tried to improve the safety of care delivery in an educational model? I know we've tried. Whether that's actually happened or not, I don't know if that's been proven. Maybe it has been. But, what do we do in the balance? Well, then people have less autonomous experiences. And are they as comfortable when they're on their own? And I think they are potentially less prepared. Although the way that you and I were prepared on some days was pretty ugly.
Yes, yeah. But you know what he said to me? He said, if anyone would ever ask me to share sort of my view with both hats and being in this game for a long time, he said, what I feel like is that some of the younger doctors are not asking for help when they should. And maybe it's you don't understand the system. So like he gave me a case of someone that was sent to an ICU, but there was going to be no ICU attending in-house all night. Does that still happen, Kevin? And so, of course, when things bad happened, there was no ICU doctor in the building, And he said, someone with really weird neurologic complaints that the doc didn't want to wake, the ER doc, young ER doc, 1 year in practice, didn't want to wake up a subspecialty neurologist to come in. And it turned out the guy had a stroke and was locked in syndrome. And, he just said, I would just say, I wish they would be humble and ask for more help and get other people involved on cases that are not just real straightforward. I don't know. I took it to heart. I thought, I'm going to keep this in mind when I'm working next, So anyways, folks, I digressed, but this just popped into my mind here.
She did. She digressed.
Big digression. Sorry. All right. Let's call to your attention something that may really be a game changer. Now it's early, and it's one article, chest pain in the ED. All right, so this is JAMA Internal Medicine, February 2018, and this is actually in a letter recounting a study. There's a study now with that looks at the 7 million people that come into the ER with chest pain. And heretofore, as you know, we didn't let them out, Kevin, without going all the way to stress testing or coronary artery CT or whatever. Anyway, the Roma-Cat 2 study, which, Kevin, you're so well-read, you're probably even more familiar than me. It concluded that actually for the medium and low risk, there was no benefit to getting this extra testing, which keeps people in the hospital longer, exposes them to radiation. There was no change in outcome. And then in fact, the patients who didn't have that, and remember we're talking about medium and low risk, they had shorter length of stay, less radiation, lower costs, no difference in angioplasty, no difference in CABG, and no difference in adverse coronary events. So I wrote to ask you, Kevin, is this a game changer? It would seem to me, now they say it deserves more study, but wouldn't this be something, and isn't this where we want to go in healthcare? We need to watch every penny, Kevin. We're on a budget now as a nation. We're on a budget. And doing tests that are not going to alter anything, that's just got to stop.
Well, you're right. You look at Roma-Cat 2 from Udo Hoffman. That was July 2012, New England Journal. Still important information, but they really were focused on, quite honestly, length of stay was the primary endpoint, and cost, and whether we can start to do CT coronary angiogram. I just really think if you have a subset of patients that you absolutely can rule out coronary artery disease and they never need another test because they're low risk enough, that's fine. If they're so low risk, they shouldn't have any testing. They shouldn't be subjected to this. And if patients are sick enough, well, they should just go ahead and get the appropriate test anyway, which might even just be a cath with PCI. So I think if we overutilize this, we're going to find some false positives, which can happen with this as well, and we end up creating a problem because we're over applying the technology. So I don't know that I'm a big fan, but I think we might be asking some of the right questions. Yeah. And I think if we can identify low-risk patients with the appropriate risk stratification, that's the key, even up to intermediate risk. But clearly, the low-risk people, if we want to use the heart, I think the heart pathway is pretty solid. And you utilize that, you've identified them, risk stratified them, and I tell you what, at 30 days, based on some of the data that's out there on the heart pathway, 0% major acute coronary event rate. So not perfect, but yet, I mean, the numbers look really good, but there's no perfect study out there. But at least you could include that in your documentation to say, I use this pathway, and shared decision-making, let the patient know, listen, you don't have necessarily zero risk, but it's pretty low risk. Are we both comfortable with you going home to get an outpatient workup? I would not go to the point where, I'm just going to do a lot more CT coronary angiograms so that I can decide who's in and who isn't and send you home. I just think that's just an overutilization of testing.
Yep. So anyway, folks, just because our world changes all the time, and chest pain is something that we certainly see plenty of, just know that the earth underneath you, that foundation may be crumbling, and the way that we have done it for a long time, the way that the American Heart Association and American College of Cardiology had us going, may not bear many fruits, and this might be changing. In the same way that, prostate care, especially prostate cancer, it's changing dramatically, and what we did 10, 15 years ago is different. So always good for us to keep abreast of these common things that we see commonly. All right, and I want to go to another category, Kevin. I'm going to call it come in dash intake. And honestly, I said this in the handout. If you are not constantly refining your intake process, shame on you. It's the process you control. You can really impact your patients. You can impact their experience of care by getting the provider and the patient together quickly. So I think you should never be afraid to tinker with your intake and try to improve it, make it more efficient. You have complete sovereignty over the intake process. That's yours. There's nobody at the back telling you how to do this. And so I love, one of my favorite projects is to go and work with an ED and help them refine that intake and make it as streamlined as it possibly can be. Anyway, that said, I'm going to throw a wrench in the works with this article. This is from the Advances in Emergency Nursing Journal, 2016. So this article is a systematic review and meta-analysis of the team triage concept. And they used the Cochrane methodology, so they searched, they got articles, they threw some out, threw some in, and they basically looked at and tried to compare single nurse traditional triage versus a team triage concept at the same place, if they could find it. So the two authors reviewed these articles. They had 165 clusters that met the criteria, and they basically looked at length of stay and wait times for patients in these studies. Bummer, Kevin, they didn't find that either of those were, consistently improved, okay? And so they said, there really isn't a lot of data to build on. I got to say, Kevin, in real life, I think there's plenty there to go on to suggest to you that anything which gets your physician, provider, and the patient together sooner, all the better. Anything that improves on communication, and certainly a team intake definitely improves on communication by its very nature. You're all hearing this story together. Oddly enough, they did find at least one study that said that team triage might reduce mortality. So I said, okay, we'll take it. In any case, we feel like you should know what's out there because sure as rain, if you're going to be introducing a new team triage and your docs are pushing back and they don't want to do it and the nurses don't want to give up traditional triage, someone might uncover this article, and I just want you to know it's not particularly strong, but I want you to know it's out there because it's basically letting you off the hook with your new idea and saying, oh, it's not going to deliver. But I believe in it. Kevin, what's your take? I know Team Health, with all of your sites, you must see a lot of innovative intake models. What's your thought? Weigh in on team triage and provider and triage kind of thing.
Well, yeah, and my experience has been the more complex a place you have and the more volume you have, depending if it's set up appropriately, it can be really helpful. Some places it just isn't necessary, and then you're forcing a technology or an innovation that's looking for a home or looking for a solution for a problem that you don't necessarily have. So when you need it, I think it's great. Team triage can be great. And if it works better than what you were doing before, you have to try it out. I think these type of processes, I've seen some people jump in and make permanent changes in infrastructure expenditures, and they don't really know if it's going to be the right fix for them. So I think you need to pilot some of these programs. I've seen them work great, other places not so well.
There is a volume cutoff, Kevin. I'm beginning to think that sometime after 32,000 visits, you might want to be thinking about a provider in triage. Below that, you're absolutely right. There's no reason why you can't use a pull to full and just get the doctor in the room as quick as possible and have that work for you.
Yeah, the minute you're going to add coverage, no matter when it is, and I agree with you, 30 to 32,000 visits, you're pretty close to saying I need to decompress the ED and use a fast track because we have enough low acuity visits that are concentrated in a certain number of hours that operationally that works, or I need to just add double coverage in the main ED because we have enough beds, or whatever it is. But when you add the second clinician, whether it's a physician or a PA or advanced practice registered nurse, you can say, now I have the option of offering this in a clinician or physician in triage. Is that the best way to add the coverage for me? Maybe it is, maybe it isn't. But when you have single coverage, you can't really do a physician in triage because I tell you what, you better be able to take care of everybody at triage because there's nobody in the back then.
Right. So all right, Kevin, I'm gonna we have a couple of stories this month, a couple of articles this month that involve Anthem. our friend Anthem Health, right? So first, and I thought this was just so clever of you to find both of these. Let's talk about the Anthem story, an ER visit and a bill. Why don't you take that away, Kevin?
Yeah, I will. And this is from, guess who? Vox. So this is from their website, vox.com /policy and politics. And I want to tell you what, they are putting the heat on Anthem. And I do like this article, but I feel bad for the patient. Here is the title: An ER visit, a $12,000 bill, and a health insurer that wouldn't pay. So it's a little bit negative spin on the ED. I don't like that necessarily. And Vox, sometimes has been not necessarily complimentary to the pricing of healthcare delivery, not recognizing the complexities of the conversation. But they're saying now this patient did not have any ability to pay for this. And the insurer, who is Anthem, denied the visit. So let me go through some of this. This was published January 29th of this year. Brittany Cloyd, and she's from Kentucky. She went to an ED. It's in the article, but I'm not going to name it here. She went to the ED on July 21st and basically listened to her symptoms. And you already know this was a denied ED visit, and it's amazing.
Yeah.
A night of worsening fever and increasing pain on her right side, quote unquote, of her stomach. Her mother was a former nurse and said, hey, you know what? When I was in nursing, that sounds a bit like this thing called appendicitis.
Mm-hmm.
So sent her to the ED after all kinds of testing, including a CT scan and ultrasound. They said, you know what? You have ovarian cyst. I'm not sure how a cyst caused the fever. I don't know all the details, but I will say that's what they arrived at. And she got a bill for $12,596 from the hospital. And her insurance said, yeah, no, we're not going to cover that because we don't think it's an emergency. So listen to this. She had her coverage through her husband's employer, and they said it was an inappropriate visit because it wasn't a true emergency. And this is based on that Anthem plan we've talked to you about that's been implemented in several states, including Georgia, Indiana, Missouri, and Kentucky, where she was from. And here's their quote: "We cannot approve benefits for your recent visit to the emergency room for pelvic pain," quote unquote. "Emergency room services can be approved when a health problem is recent and severe enough that it needs immediate care." Their Anthem letter that went to her, the denial letter, goes on to say things like stroke, heart attack, and severe bleeding are examples of what would be acceptable to use the ER for. That's absolutely what they said.
Are you kidding?
Yeah,
oh my
so
gosh.
Come on. And so the article also states that, as we know, Indiana implemented this type of policy in 2015, limiting visits. And the Trump administration recently approved a request from Kentucky to do the same. So this could be happening by other mechanisms also. And beginning in July, Kentucky will charge Medicaid enrollees $20 for their first inappropriate emergency room visit, $50 for their second, and $75 for their third. Now, I don't know the details of these programs yet from Medicaid, but I tell you what Anthem is saying is, we don't care. We're not paying any of it. A copay is different. A fee is different. But I tell you what, saying you were doubled over in pain, you reasonably thought you could have been really sick with appendicitis, and you did need the workup, and you did need pain management and everything else. By the way, because it was an ovarian cyst, you're being retrospectively denied access, and we're being retrospectively denied payment for the services we provide, and it is not fair. So I'm glad this is seeing the light of day, because this is a really, really serious problem.
Yeah, and I'll tell you what, if it seems like they can get away with this, can you just hear the rumbling? I mean, this would be a tidal wave of payers not, using this kind of logic to not pay for after an ER visit, and it's just, it's funny because it goes so against the prudent layperson's, the old thing that we used to go by, which is, if the prudent layperson thinks that this is an emergency, they should go, and we've always encouraged that. So I don't know, Kevin. I think it's going to come down hard on Anthem. But what do you think?
Well, I do too, but these initiatives continue to come up. This has been one of the largest in recent years, but I know that there are a lot of denials out there, and there's significant impact. And I do know that, and we talked about, I think it was last month, that the Senate is taking this up and asking questions and demanding answers to make sure that this is just not irrespectively trying to deny coverage so that they can save money. And I understand trying to be trying to be responsive to the need to perhaps decrease inappropriate use of the ED. And maybe there is a small number of lower acuity visits, if you have access, that could go elsewhere maybe. And we know some of those are out there. But you see what they have on their list, and this is a very, very good example. Instead of looking at a list, seeing a real-world example of what they're doing, and this flies in the face of the prudent layperson definition and standard, as you just mentioned, Shari. And that's what's going to end this nonsensical behavior from payers.
Yeah. All right, so and let me move on, guys. I've penned a new title. Kevin's rolling his eyes. Heaven help us, right? So I'm calling this the doctor's pen, and it's going to be about utilization, what you order. And I want to lead into there by telling you about an article that's in the Journal of Community Hospital Internal Medicine Perspectives, if you knew there was such a journal. Say that again, Journal of Community Hospital Internal Medicine Perspectives, February 2018, so it's hot off the presses. And it was looking at the use of CT pulmonary angiogram in a teaching hospital setting. Now remember, there are a lot of different scoring schemes for ruling out PE, including, and it's still been proven to be valid, physician gestalt, right, Kevin? Did you worry about that? Did the patient's presentation make you want to rule out PE? And that is actually considered to be a fairly reliable, method to use as opposed to any of your other scorings. In any case, they looked at CT pulmonary angiograms that were ordered, and the prevalence of PE was 5.4%. And Kevin, I thought, gosh, for an entity that is very high risk, i.e. could kill you, and sometimes very, very atypical in its presentations, you know this, the number one unexpected finding at autopsy, folks, is PE. It was missed as a clinical diagnosis. So I thought, well, I don't think that's necessarily bad. But they went back and using some of the scoring systems, felt that 41% of their CT pulmonary angiograms were inappropriately ordered. I say if you're allowing physician gestalt, none of them inappropriately ordered. But in any case, I had a feeling this is an imaging department that is mad at the ED for ordering too many CT pulmonary angiograms. In any case, this is the kind of thing that's going to be smacking us around, Kevin, as people try to get a handle on utilization. One thing that you have to know is there's great variation in the use of imaging modalities and other modalities, but especially I've seen it in imaging around the country. Whether you are a teaching hospital or a non-teaching hospital, whether you are higher volume, intermediate volume, or low volume, often can play into what's the normal for that group, for that cohort. So as a little gift to you, I've put together some utilization. And remember, there's two ways to measure utilization, as percent of visits with, or units per 100 visits. And when you think about that, those are really different. So I've got for you EKG labs, X-rays, CAT scan, and MRI. I've got it from NAHAMSIS 2014. I've got it AAEM. And then I also got from the ED Operations Study Group, which is a small group within ACEP now. And Maya Iadam heads that up, folks. I got some of her data. And then I've got the Benchmarking Alliance, the EDBA, and I picked a middle group. I picked rough 60 to 80,000. If you want a different volume bad, you can just email me. And I'm actually going to put it in the handout for you because I think it'll be interesting for you to see where these fall in. For instance, labs, NAHAMSIS, 42% of your visits get labs. The ED Operations Study Group, 61%. That's off by 50%. And so I just want you to see that there's variation in what's out there. Does anybody know the truth? Where's that white kernel of truth? We don't know it. But what I want you to know is that I really believe in this coming era, especially with the ability to track this sort of thing, be prepared as a group, as a department, to come under siege a little bit with the criticism that you are high utilizers, you are over-ordering, and kind of know where you fall so you can be prepared. What do you say, Kevin?
No, I think you outlined the data really well, and it's important. I think last time we talked about the significant variation. When you looked, I think the article we talked about was roughly 29 different hospitals and EDs. Mm-hmm. And if you looked at the different Hospitals, just at the hospital level, 100% variation. Looked
Yeah.
at the physicians among those facilities. The variation among all the physicians was 400% variation. You can't justify that. And you made me think about something too, so I pulled this article real quick. But this article by Hutchinson, August 2015, American Journal of Rentgenology. And I'll tell you what, we assume that when we order a CT pulmonary angiogram, hey, you know what? If we decide to do it, it's a really good test. There's some limitations. What they reported on, and I don't want to spend a lot of time going through the details, but I want to highlight a couple things, is even when we overorder, it doesn't mean that we're getting the right information. CT pulmonary angiogram false positive rate is up to 42%. If
Wow.
you do it in low pretest probability people. If you are not selecting out the right people, you are going to get a lot of false positives that then you feel validated because, oh, thank goodness I did it. You know, I guess I was thinking the right way because I got, I got the right answer, and thank goodness I did the test, and then you might be more likely to order it again. And what was really impressive, they looked at 174 people who got a CT pulmonary angiogram. It was positive for PE, and by the general radiologist. And they blinded chest radiologists. They just reviewed these studies regularly, and they gave them the studies and said, tell us what you found. And it was pretty impressive. So when we look at the discordance rate between what was initially decided on the film and what these chest radiologist specialists decided, if it was a lower lobe solitary subsegmental PE, the discordance rate was 66.7%.
Wow.
Meaning so when you see those, lower lobe, solitary, subsegmental, particularly if you realize they're really a low pretest probability person, you should say, wait a minute, maybe this isn't really a PE, it's artifact, it's something. They said that motion artifact, beam hardening artifact, poor contrast opacification, all of these things play into it. And the test isn't perfect, and the radiologists reading them do not agree on what they're seeing.
You know, and someday I want to understand, like, I believe that there are likely generational differences in how we utilize now. So do you know what I've been doing lately? Now, folks, this is not published. This is just Shari's library, all right? So I've started to ask for the mean age of the physician group in practice and then look at their utilization. And I will say this, I have noticed that groups that have a physician mean age of greater than 50 often have lower utilization. Like I said, folks, not publishable, just stuff I'm seeing, and it's caught my eye because I'm a data junkie girl. Younger doctors, slightly higher utilization. And I wonder if it's because, say, Kevin, do I dare date myself? I had a half CT pulmonary angiograms when I started practicing. I didn't have some of the things. Didn't have MRIs, you know? And so I'm just wondering if we are trained to depend more on certain, modalities based on which era we trained. Anyway, I think that would be a fascinating study to look at utilization by age. And what our practices are. Yeah, go ahead, Kevin.
Yeah, no, and I think, it would be easy to be concerned by a statement like that, but I think it is generational. And if you had CT pulmonary angiogram available to you, actually, Shari, if you actually had plain X-ray available to you when you were trained, I'm just kidding. I'm just joking. But if you had those things available, you would have used them. We wanted those things.
Yes.
And if you train in an era where it's available and it's helpful and it's useful, of course you're gonna be trained and you're gonna feel comfortable in utilizing them. So it makes sense. But the question is, can we also curb it on the top side, saying we have to decide when it's most appropriate to utilize them. And I think we all overutilize at this point. We know the variation, as we talked about, is significant. There might be breakdowns in different populations and in different age groups, but at this point, there's so much overutilization. I think we all need to reel it in.
Yeah. Yep. All right. I'm going to talk to you as a sort of a fast takes idea, something called the PASS system, PASS. And this is, you're going to hear me talk a bit about Centera Lee Hospital in Norfolk, because they just have they've just rocked it in terms of their ER. They re-engineered it and they did a lot of changes. But one of the change that I think is going to be so compelling is they have made sure that every patient has an attending that comes to their department. Even if there's no bed and even if they're going back to the waiting room, they have an assignment. And guys, I think this is something that you should think about. I may have mentioned it last month because I just was getting so excited about the notion that we have to take ownership for the waiting room. And I for one, I'm tired of going to emergency departments where I see people feeling and acting like the waiting room is not their problem. If the patient's not in their little pod or their little area or their little zone or whatever, that's not theirs. I will tell you, and Kevin, with his wearing his legal hat, hat and coat, anything happens to that patient in the waiting room, whether you put your initials on or not, you own that problem. And so I loved the fact that they did this. What were you going to say, Kevin?
Well, I first want to say that it's just a hat. There is no coat. It's a hat only. But, in the waiting room, it's changed because traditionally, through traditional triage, generally speaking, the nurses work for the hospital and the nurses manage the waiting room. The doc oftentimes doesn't even see the patient until they get in the back. But when you don't clarify whose responsibility it is, it becomes all of our responsibility. I remember a case that did not go well several years ago where there was a patient who was triaged, had thigh pain, was sent back. It was a busy day and was sent back to the waiting room waiting for a bed, arrested in the waiting room. Actually ended up at AAA with radiation down his thigh. It was an unusual presentation for sure. Well, the doc got named in a lawsuit also. He never knew of the patient until he was resuscitating him. But what needs to happen is clearly defined roles. Who is responsible for the waiting room? What are we going to do? And then with, as you mentioned earlier, Shari, team triage or clinicians in triage, we've started their care.
Yep.
So now you are involved, and even if it's standing orders from you and the patient goes to the waiting room and either leaves or has a bad outcome, you can't hide from that. So we have to manage that and make sure that when we do start the orders and they go back to the waiting room, we need to reassess them, whether it's triage nurse or whoever it is, once an hour. I need to retake your vital signs or whatever it is because we started the care. So out of sight, out of mind is a philosophy that's going to get you into trouble. And it's not true. You know what I mean? Like that they're not your problem. Now, so come follow with me, folks, because I feel like you're thinking, where is she going? I mentioned where are you going, Shari? Where are you going?
This PASS system, which I'm going to explain to you in just a second. So we have a problem of unassigned patients in your department, and somebody needs to be attached to that person and responsible for that person. We also have a problem, and I find this is one of the most the biggest dissatisfier for emergency physicians, and that is when you're working and you feel like your area, now obviously this isn't single coverage, this is any place that's got double, triple, or more, that your area is getting unfairly loaded with work relative to your partner. In some places, now see, Kevin, part of me doesn't get this because I just went to work and I just took care of my zone, you know what I mean? And I never, there were doctors in my group that at the end of every shift counted how many patients they saw versus how many patients everybody else working, because this was important to them. And they were very dissatisfied at their partners that had low productivity. They were very dissatisfied if they felt that the nurses were giving all the bad patients or too many patients to their area. So the concept of load leveling and fairness and parity at work is big. Now, you want to jump in, Kevin, say something?
Just a quick comment, and I'd love you to respond too if you know. But yeah, I think if people are working really, really hard and they perceive they're working harder than others, and they're not in an incentive-based compensation program, it's really frustrating for them because they feel like they're subsidizing the other people economically. Now, they may not want the extra dollars anyway because they don't want to be overworked. It may just be simply that they want load leveling and they want everybody to work the same. But on top of it, if it's also you're getting paid the same hourly rate no matter how many people you see and you are being more productive than somebody else, there is a limit, and that's why you count. I always like to count my patients just so I know what my productivity levels were. Gosh, I feel pretty tired. I feel like I beat myself up today. How many did I see? Yeah. But I'm not really comparing myself to others and comparing myself to me.
Yes, I did the same. I used to write a little card to remember who I saw. But in any case, okay, so the problem of unassigned patients, the problem of load leveling. So there is actually a cloud-based solution called the PASS system, Patient Assignment and Sorting System. And if you want to know more about it, you're going to have to contact because I actually couldn't find a link on the internet, but the Centera Lee system in Norfolk, they use this so that, remember I said every patient that comes in is automatically assigned to one of their areas. They had several areas, zones in the department. When they had no more space, a physician who got a patient assigned to them would have a choice. He could move somebody out who he thought, oh, she's almost ready to go. They created internal waiting spaces and pull that patient back, or they could go out to the front with their team and see that patient. Sometimes it's just a relief to look at the person and go, okay, you're not dying, you're good, I'm going to order this, and I'll try to make a bed for you as quick as I can. But I loved it because this now solved two problems. No one was arguing anymore about the assignment because the cloud-based system took into account the number of patients in an area, what their ESI was, what workups they were having, and so forth, and tried to load level the two or three or whatever zones. And it also now had everyone assigned. So, and you know what, the places that are doing this, and I'll keep you posted because Virginia Commonwealth University is about to trial this 100% patient assignment in their acute care areas. What they're going to do is now a doctor knows, I can't get away from this. This patient is coming to me. So do I want to move and pull them back sooner? Do I want to go and see them and get them started sooner? Or do I want to wait? Most of us are uncomfortable having patients assigned to us that we have not seen. So I think it's a great strategy, folks. And I just wanted you to know there are developing cloud-based and IT solutions that help with load leveling. And I want you to toy with the idea, how could you make sure that every patient that's on your tracking board has a home, so to speak, a team that is going to be taking care of them, even if it's just to eyeball. And that the idea of people waiting for hours in the waiting room just because you're busy, that's just not flying anymore. All right, so Kevin, now I'm going to give you the Buck Stops 2. The Buck Stops 2.
Sounds good.
Back
Common
with
theme.
Our friends at Anthem. Yeah.
Yeah, and you know, you wonder what's happening on the other side of the equation. And I'll try not to insert my personal opinion about this, but you have to wonder when the Anthem policies are top of mind for us and we're worried about patient access and reimbursement. Well, maybe it is difficult out there for insurance companies to survive, and they're trying to reduce providing services for things that aren't providing value, and maybe they feel like they shouldn't pay for certain things. And they can't pay for everything, so I get that. But then when you see an article like this that's in Healthcare Finance News, February 1st, and the headline is Anthem's Profits Skyrocket 234%.
234%? 234%. Folks, that's what he said.
It's not even a real number. Could you imagine talking to people you work with? Hey, listen, I need 234% from you today. I mean, you can't do that.
Right.
But I tell you, you know, it's really hard to be sympathetic or even empathetic. Because it's wow. So here's the quote. Profits soared by 234% to $1.2 billion in Anthem's fourth quarter compared to $368 million for the same period last year. This was from their earnings report Wednesday, which is just prior to February 1st. So full year 2017 financial results were also strong. Anthem reported a 55% increase in net profits year over year of $3.84 billion compared to $2.47 billion in 2016. So during the fourth quarter, Anthem recorded a one-time non-cash deferred tax benefit from corporate tax reform of $1.1 billion, reducing the total income tax expense in 2017 to $121 million, an effective tax rate of 3.1%. I think the tax cuts can be great. But here's an organization that isn't returning it to anybody. It doesn't sound like it. Maybe it's not reported here. Maybe they're doing something for their employees. But why not allow patients to go to the ED?
Right.
Why not pay for those services? You got this huge tax break. And then there's a quote here. I'll just share with you if I can find it in the article, but it basically was from their CEO. Let me see if I can find it. Yeah, here we go. It's right here in the article. So looking ahead, we see opportunities to continue to leverage our deep expertise in Medicaid to form new partnerships and alliances with our Blue colleague providers and other health plans to expand our presence and reach into new markets. I mean, it's just, I don't know. I just get the sense that...
It seems so brazen in lieu of the other articles and the other things that are afoot.
Well,
doesn't it?
yes, I think they're absent in the conversation largely that the patient and the clinician provider community is strongly reacting to their policies, but yet, this kind of article is out there. I don't think you can really speak to this very, very positive financial performance and not speak to how this has been impacted by your decisions to provide coverage. So the final quote basically by him was, "We are pleased with our 2017 performance, which is the result of improved execution in all areas of our business and an increased focus on aligning strategic investments and capabilities to more effectively meet the changing needs of the more than 40 million consumers we're privileged to serve." To me, that runs counter to the policy.
Yeah.
To me, it does, and maybe I'm biased because I see it from the other perspective. But I don't know that you can really claim you are engaged in trying to provide service to insureds and consumers who are privileged. You're privileged to serve when somebody gets a large bill for a legitimate ED visit and she can't pay for it.
Yeah. Yep. But anyway, like I think someone should take out an ad in the New York Times and put her story and the profit data, 234%, side by side. Don't you think that would be a revelation for the public?
Well, it may be. And I don't think, if the insurance company is strong, then they're going to be able to provide more service and more value, and they'll be around and people won't lose their coverage. So we want them to be operated well. But
Right.
when they're doing what it sounds like they're doing that well, and yet they are limiting services and coverage that we think is an essential healthcare benefit, and it is listed in the Affordable Care Act as an essential healthcare benefit. I think those two things are in direct conflict, and I think they should really make sure that they're providing the right service to the right people, which includes emergency services, which should be defined by the prudent layperson standard and definition, like you said earlier, Shari.
Yep. All right. Well, thanks for that, Kevin. That buck stops too. Under mouse clicks, really kind of fast here, because I just wanted you to know that this sort of thing is emerging in an article called "Oiling the Gates." From, again, I didn't even know this was a Journal of Community Hospital Internal Medicine Perspectives, February 2018. There was an article again about this ED inpatient interface. So the ED is trying to admit to academic internal medicine at a big community teaching hospital. And there's all kinds of variability. You understand, some of you are operating within schemes that it is wonder anyone can get admitted because the rules are so complicated and so forth. So they created an app that would help the ER know who was up for the next admission. Oh, by the way, it load leveled on the internal medicine side. There's that issue again. Hey, I got more admits than he did. How come I'm being penalized and so forth? In any case, it was apparently a phone app they developed that would help the ER to sort of understand what beds would be available, who would get the next patient, where they'd go, and so forth. So I think we're going to see some more little IT solutions along these lines, and I just wanted you to know that this was out there and starting to emerge. All right, under director's chair, Kevin. So you found something called the Aspen Report on the Opioid Crisis. Anything new in there?
You see a lot of white papers that come out and they're distributed, and sometimes you click on them, sometimes you don't. I got this one, and it's from, and I hadn't heard of them before, the Aspen Health Strategy Group. It's titled Confronting Our Nation's Opioid Crisis. And, kind of like disaster, I hate to admit this, but kind of like disaster preparedness was after 9/11, I'm kind of getting saturated with the people giving their recommendations, and oftentimes they're not really that well informed. Some are, some aren't, and they are very good about identifying the problem, but they're pretty short on the solution end of things. And I don't know that we need to hear about the problem too much more. We get it. We need people to understand that the ED is not the source of the problem. We do contribute to a certain degree, and we need to make sure that we're responsive and responsible for the portion that we can control. Absolutely. But we are prescribing and always have been prescribing less than 5% of the immediate release opioids. And we have been the number one, Scott Weiner published an article a few years ago, number one specialty to reduce the amount of prescribing, I think by 8.9%. 100%. So we are responsive. But what caught my attention initially when I looked at the first couple pages is who was involved. And that's why I started to look at this 133-page white paper.
I know, Kevin. You lost me after like the first 10 pages. So I was like, okay, I'll let Kevin summarize this.
Yeah, I've dove in. I mean, I needed to leave breadcrumbs to find my way out of this white paper. So listen to this. Who are the co-chairs? Kathleen Sebelius, right? Remember? 44th governor of the state of Kansas, 21st U.S. Secretary of Health and Human Services. No, she doesn't work there anymore, but she did for 5 years. Tommy Thompson, 19th U.S. Secretary of Health and Human Services from 01 to 05, and the 42nd governor of the state of Wisconsin. These people have great experience. The members, just a few of the members who are involved. Marcia Angel, I don't know how to pronounce her last name necessarily, but I did my best. She's a former editor of the New England Journal. Richard Barron, President and CEO of the American Board of Internal Medicine. Mark Bertolini, Chairman and CEO of Aetna. And Richard Besser, President and CEO of the Robert Wood Johnson Foundation. I started reading these names, so these people are smarter than me. Yeah. They're heavy hitters, and there's a whole list. I'm not going to read all of them. Okay. There are a whole bunch of people, and if you want to look at this, you certainly can. I think it's open access, and I can provide the link to it, and we'll try and do that. They do a nice summary. A nice summary of the problem. I'm not going to go into that here, but they really summarize some of the data and statistics and where we're headed and lots of different things there, and it's helpful. What I liked about it is they said, we're going to give you 5 solutions, 5 areas to focus on. Maybe not all the detailed programs, but here are the 5. The first was stop overprescribing. Now, they're broad. They don't really focus on any one physician type or specialty, but a few things they mentioned. There are a few strategies they listed. So the FDA should increase its oversight of the marketing practices of opioid producers. When you look at the background on this, it has been driven to a certain degree by the pharmaceutical industry. States should adopt best practices for prescription drug monitoring programs, including comprehensive data collection, integration with electronic health records. Absolutely. And if we're pushing this, maybe it'll get done. Encourage continued dialogue regarding voluntary and mandatory limits on the duration of initial and subsequent opioid prescriptions. You know, I don't think these are a good idea, but it sounds like people think that it is, and this is what a lot of states are doing. But I tell you know, it seems silly to put a number of days on something when, especially in the ED, when the ED isn't the source. I'll give you a good example. Some states are saying 7 days. Well, if you prescribe 2 hydrocodone, every 4 hours for 7 days, I think if the math is correct, that's 84 pills. Have you ever prescribed 84 pills?
Oh.
It doesn't, it's not, this doesn't make sense. So I don't really like that approach, but I think we have to have reasonable prescribing and continue to update clinical guidelines based upon the best available evidence. Well, I'll jump into 2, 3, 4, and 5 really quickly. Treat opioid addiction as a public health crisis. Absolutely. Bring down the stigma. This is a mental health issue. We need to help people instead of saying those are those people who are criminals and what happens to them. That is not fair. This is everybody's problem. We need to identify them. We need to note it as a chronic disease, and we need to get after this. Stop the deaths is number 3. More than 30,000 people died from an opioid overdose in 2015. And I've seen other articles, one that was recently published. I loved reading it when we put it in ACEP Now, liking the numbers to when the HIV crisis was out there with AIDS. I mean, that was a public health crisis. We looked at it differently when we looked at that from an infectious disease perspective. And so stopping the deaths, including making sure that naloxone is available, just like AEDs are, and making sure that we do not put barriers up for people who are administering or prescribing naloxone. Number 4, guarantee access to treatment. Get people under Medicaid expansion treatment to make sure that they can get treated for this. And it's about long-term treatment. Medical assisted therapy is the way to go. Some people are saying it's a lifelong treatment. And I don't know the answers to it, but it's not treat them for a few weeks in an outpatient setting and they're done, or admit them and then discharge them back to their environment. This is long-term treatment that's really important, and we have to look at the evidence and approach the treatment of opioid addiction based on the evidence. And the fifth is invest in data and knowledge. We need to know more about this. We need to know what's going on in our communities, and we need the information. They have several strategies and tactics listed. I won't go into them, but I do like this white paper, and I think it starts to focus our attention on solutions, not just the background problem.
Okay, all right. And so, folks, we'll leave a link for you to look at this white paper if you're so inclined in the handout. All right, I want to talk to you operational improvement for this month. Let's talk about low acuity service lines, and let's clarify some of the language around them. And I want to remind you, though, your admitted patients, particularly if you're boarding, just kind of suck the oxygen out of the room and they preoccupy you. But for most of you, 70% of your patient population is ESI 3 or lower acuity, 3, 4, 5. And for most of you, 80% or more are going home. So from that sort of background, let's talk turkey a little bit. If you hear the term rapid assessment unit, now this was I first came across this in the Urgent Matters. Lehigh Valley wrote up what they did, and they basically used rapid assessment unit as a place to get the provider with the patients when they were full and get their workup started. And obviously, if you recognized somebody that was going to be sick, they went back and you made a bed for them. Other patients might actually finish their workup without ever getting back and occupying a bed. So rapid assessment unit, and I'm seeing it now. Here's one at Scarborough Hospital. Here's one at Nova Scotia Health Authority. I mean, so it's that's, I think, taking off. Jody Crane pioneered the term super track for very, very low acuity patients. I want to suggest to you that you may be able to send a good 10% of your patients home from wherever you're doing intake, especially if you put a provider there. So think about a super track as being for the very rapid turnaround, kiss them goodbye kind of a patient. All right, fast track, long-standing, 30 years background of fast track, typically for very minor medical issues, but also for the 4s and 5s, heavily slanted towards procedural. We've tended to put our nosebleeds and our, things that needed procedural care, but we're other patients who are otherwise healthy in those fast tracks. As we grow our geriatric population, you're going to need to decide, do you need an age cutoff? I just worked with an ER they have a lot of geriatrics, and they said, you know what? Every time we put a geriatric patient in our low acuity area, we get bogged down. It's not just a laceration. They're on Coumadin. They've felt faint, whatever. And so they've said 65 or older. I've seen somebody use 70 and some use 75. We don't think we'll send those to our lower acuity area, especially if it's a fast track and meant to really rock. You may not, you're hearing more and more, and I've talked to you about mid-track, the idea that you would have a space for your ESI 3s. Sort of rough rule of thumb, about half of your ESI 3s you ought to be able to treat in lounge chairs in a vertical model. And set your targets. The best performing ERs I'm seeing, folks, have specific volume and time targets for each of their zones, and that's how they get to this highest level of performance. All right, then finally, how about the rapid treatment unit? This is not rapid assessment unit. This is rapid treatment unit. Let's say you're a smaller ER, maybe you're seeing 28,000 visits, and you couldn't populate both a fast track and a mid track. You just don't have the volumes. Could you create a hybrid that's a lot of the procedural, real fast stuff, but also some of the people that could keep vertical and sit in a lounge chair, could they also go to your rapid treatment unit as opposed to occupying a bed? So low acuity service lines, once you start thinking about them, there's a lot of research afoot. People are experimenting. It's a very exciting time for low acuity service lines, I think, in emergency medicine. So let's think about those. Kevin, anything you want to say about that?
No, you've covered it all, Shari. I couldn't agree with you more.
Just the point is, folks, that just even though that you get a lot of heartburn over your admits, let's not forget these patients that you can just really rock. And every time I see a department skimping on those low acuity service lines, I just shake my head. I'm like, guys, that's the majority of who you're taking care of. I recently watched an ER that had actually great performance, had chipped away at its low acuity service lines. It had a mid track, it kept cutting space. It had a fast track, kept cutting space. And now it's really in the toilet, Kevin, because it just can't move any of the low acuity. So dedicate some resources, some time, some thought to your low acuity service lines. All right, news you can use. I talked to you about how getting patients home from the hospital, how that's become a problem with everybody working. There's no stay-at-home mom anymore in many cases to drive Granny home from the hospital. I mentioned that to you, and I'm excited because I just discovered a new commercial solution. Please, this is not an infomercial, but I want you to know these things are out there. It's called Round Trip. It began in the Richmond, Virginia area, and basically this company, it's a startup, will get your patients transported home. They provide medical screening. They decide whether you need an ambulance, whether you just need a medical van, whether you could just go home in, say, even an Uber-type arrangement, and they arrange it for you at a fraction of the cost of some of these old traditional medical transport services. So take a look at it because this might help out your community and your hospital to decompress. What were you going to say, Kevin?
Yeah, that reflects back on what we discussed earlier and the frustration that we've been talking about the same concept for over a decade. Well, where is this available? Is it local? Is it regional?
Yeah, and so they've gone national actually, and they're doing some very big systems. And you know what I'll do, Kevin? I'll put the link in the handout for that as well. And I don't think it'll be the only show in town, but I was excited to see this. So
I'm just glad there is a show in town because I think we need real solutions for that problem.
Yep. And like I say, I want you guys to look really just so smart at these meetings when people are discussing this and gnashing their teeth that you're going to actually have some solutions that you can pull out of your hat. All right, Kevin, under Money Matters, you have a piece called Macra Panel.
Yeah, I just want to share it with you. We didn't get it in the last couple times. It's from November 6th of 2017, and it's from Becker's Hospital CFO report. And it's about the physician-focused payment models that are being developed out there. And, you can look at, being involved in MIPS. And if you perform really exceptionally well in MIPS, you can get a 0.5% bonus. You get all the way up from a 70 to a score of 100. You can get a 10% bonus. Pretty hard to do, I think. But if you are involved in an advanced alternative payment model, you can get a 5% bonus. And the physician-focused payment models can certainly apply for this. So there was a committee developed a while back under MACRA called the Physician-Focused Payment Model Technical Advisory Committee, PTAC. And they have one role, and their role is to look at these models from a physician and clinician perspective and say, does this make sense and should we approve it? They recommend it to Health and Human Services, who would then support it and approve it. There have been just a few of these that have been approved, and I'm going to mention from this article 2 of them that the PTAC recommended that Health and Human Services go ahead and approve. So they recommended that they implement a hospital at home plus model. What this is basically, it came out of Mount Sinai in New York, and it outlines a way to provide home-based hospital level acute care and tie it to value. So get them out of the hospital, but provide that kind of care at home. It's the first model the committee has recommended for full implementation. And there are some great benefits to it. I won't go into all the details about it, but one to share with you is that the model includes at-home care for the illness plus 30 days of transition services post-discharge. So it would include all of that. And basically, the care teams would have to beat spending during this episode of care compared to that of what would have been spent if they were treated in the hospital. I think that would be easy. But anyway, that's why it got great attention. The second model is one a little different, and it's based on oncology services. So it's Oncology Bundled Payment Program using CNA-guided care. So this was from Hackensack, New Jersey with Meridian Health and CODA. And CODA is a precision analytics company, so it's pretty interesting. And the PTAC said, yeah, we think it's good. You have 27 bundles for oncology care, predominantly in breast, colon, rectal, and lung cancer. But the PTAC said, wait a minute, we would like you to include this as potentially another initiative that's going along with something the American College of Surgeons is working on, and let's do a limited scale testing to see if it'll work. So they didn't recommend full implementation. So those are out there, and I'm excited to tell you ACEP is making great progress on their physician-focused payment model that they have submitted to the PTAC. A PTAC has reviewed it, and the PTAC is interested. There is a meeting scheduled with CMS and the PTAC for ACEP leaders to go over this with them. And it's called Acute Unscheduled Care Model. And it took a while for ACEP leaders to develop this, but I'm excited because they will look at providing value in patients coming to the ED with 4 presentations: chest pain, abdominal pain, syncope, and altered mental status, and looking at the outcomes of death, repeat ED visits with discharge, observation stays, and inpatient admissions. And I think it's a well thought out plan, and this could be actually a plan that we could participate in because it would be designed for us by us, which is super exciting. I have my fingers crossed that PTAC will recommend to Health and Human Services that this get approved for full implementation.
Oh, great. And any idea when you might know, Kevin, whether it's going to...
I've asked that question.
Is this a couple-year process, or what do you think?
I don't know. I asked the same question, and I will tell you, the legislative division of ACEP is really, really good at these things, and they've pretty much said Health and Human Services will function at their own pace for implementation. So we don't know. But the big hurdle is to get approved, and what's nice is that AUCM, Acute Unscheduled Care Model, is well downstream in the process that it has momentum, and I'm pretty optimistic that it'll get approved.
That is just great. That's really good news. All right, on operational improvement 2. So I mentioned to you the Centera Lee ED, and they just blew up the way they did things in Norfolk, and it's such a great success story, Kevin. I think I'm just going to have to get it off my chest, write it for Special Ops, for you, for ACEP Now, and get that, the whole thing published because it's just such a great story.
Yeah, do it.
Anyway, folks, just to give you an so in 2016, they just re-engineered and did a bunch of improvements at once. They did the PASS system that I mentioned to you, where they have an patient assignment system so they don't have to argue and worry about he's working harder than me kind of thing. Their door-to-doc before was 64 minutes. It's 22 now. Their fast track was patients stayed 108 minutes. They stay 67 minutes now. Do you realize how rocking that is to get patients out in just over an hour? Their ESI 3 patients used to stay more than 3 hours, 228 minutes. Now they stay 169 minutes. I mean, it's just been stunning. Their left before treatment complete went from 3.4%, which wasn't terrible, to 1.4%. They're left without being seen down to 0.4%. I mean, this is just stunning. But some of the features that I wanted you to know were how they divide up. So remember, I've already told you, every patient, as soon as they come, they are assigned to somebody. And often the doctors will come out and see the patients and start their workup if there are no beds. And if they think they need a bed, they are shuffling their beds. Each doctor owns their zone. They also did this. They created acute care teams. And this is a question that we really don't know the answer to. How big should a zone be, a geographic zone with a team? Should it have one doctor for 10 beds, one doctor for 8 beds, one doctor for 20 beds, and I'm telling you what, I've seen it all over the place, okay? They said, we're going to give you 8 beds. We want you to be mindful that our beds, our acute care bed space is very precious to us. And so we want you turning those beds as quickly as you can. Get people up, put them in discharge chairs, and let's just keep the fluidity going. How many nurses does one doctor need? So they gave, might be surprised, 2 to 3 nurses for those 8 beds and a tech for that zone. And they set expectations. Their goal, even in their acute care area, Kevin, is to see 3 patients an hour. So they set these targets. Remember what I'm telling you, geographic zone with a team dedicated to a certain acuity level of patients with clear goals for how quickly you'll turn patients and how many you will see. And that's how you take that ER to just the highest level. All right, Kevin, so under mistake proofing, You've got a case to tell us that I think is a kind of a sad story. Talk about the Florida amputee.
Yeah, I just wanted to share with everybody that there is a significant trend going on out there for excess limits cases, meaning beyond where the insurance coverage ends. So this is a case out of Florida. This was published in Law 360, and this was January 26th of this year. So make a long story short, and I will try and make this short. Person came in for an ovarian cyst excision. She was going to have it done by laparoscope, and there was a bowel perforation, and you can see where this is going from there. So she got sicker, ended up with sepsis down the road, and ended up, of course, with gangrenous arms and legs, and then, of course, multi-organ failure, and just like other patients with sepsis, ended up with limb amputations. So when you see this type of case, I mean, it could happen to anyone who ends up in sepsis. This obviously was a surgical complication, which makes it that much harder to defend. But nonetheless, when you have these horrible outcomes, we're seeing these horrible damages and these outpourings of sympathy from the jury expressed with excess limits judgments. So this person was awarded $109 million.
Oh my God.
I'm not saying that there wasn't potential negligence. Maybe there was. That's not the point of me bringing this up. The point is that, wow, when you can see that $109 million in current times, I mean, that's a pretty adverse judgment. So just be aware of it out there. Another reason for sepsis, whether we think there was a complication or not, sepsis should be really a concern for us from a risk management standpoint.
Wow. And that was Florida, right? That was the Florida case.
Right.
All right, folks, one last thing, because I just got to get this goodie to you because I think you'll really appreciate it. We're realizing that getting ready to take care of sick children, they're not just small people, and there's something to it. So I wanted to provide you with a link to an American Academy of Pediatrics and ASAP like a toolkit called a pediatric readiness kit, especially if you're putting yourself out to the community as having a pediatric ER or pediatric service line, and it goes through the things that are really needed. So I want you to have access to that. Follow the link. It's got some great tools, and it tells you how you would be ready for pediatric cases. As you know, many adverse events occur in the pediatric population in the ER. They are really at risk. And my one little final reminder, please disable your pediatric scales. Have them only weigh in kilograms, not pounds. I just came across another just terrible case where the kid had been weighed in and no one realized it was on pounds and not kilograms, got double dosed on everything, and it was catastrophic. So remember, there's no reason you should be weighing pounds in your emergency department. And Kevin, I think that's all. We're going to have to save the rest for next month.
Absolutely. I wish we weren't out of time, Shari.
Yeah, gosh, we enjoyed talking to you folks. Stay tuned next month and we'll be back. Take care, everybody.
Bye, Shari. Bye, everybody.